Hello everyone. Discussing a case of 80-year-old woman present to the emergency department with a recurrent episode of sudden collapse. She has been incontinent and the provisional diagnosis in the emergency department is of seizure. She was asymptomatic when this ECG was recorded but has been missed. It was a provisional diagnosis only and this is the ECG. What we should understand. So let's starting with the ECG findings or ECG, the protocol analysis. See, first the rate of ECG. You count the first 50 big box, the rate of ECG. The first 50 big box is from here to here, 50 large box. And you find that how many QRS complex. Why? Because this is an irregular rhythm. You see this interval, this interval, this interval, everything is different. That's why we are using this, counting the 10 seconds number of QRS complex. There are 11 QRS complex. You multiply it by 6, it will be 66 beats per minute. Okay, that is about the rate. Next comes the rhythm. The P wave follows QRS. You see here, this is a P wave, QRS is there. P wave, QRS is there. It's the beat. You see the P wave, QRS, P, QRS. Here is a missed beat. So these are not at all a regular rhythm, it's a irregular rhythm. Next comes the axis. For axis, we check lead 1 and lead AVF. Lead 1 is positive, lead AVF is negative. So you check the lead 2. Lead 2 is negative. So the axis is left axis deviation. Since lead 1 is positive, lead AVF is negative and lead 2 is negative. So it is left axis deviation. Next comes the P wave. Check the P wave in the lead 2. There is no much difference or much problem in this P wave. So the P wave is normal. Next comes the prior interval. In the lead 2 rhythm strip, you check the PR interval. First, from here to here, there is 9 small squares. From here to here, there is 11. Then here is a missed beat. Next, 7 small squares. Here, 9 small squares. Here, it is 11 small squares. Here, it is 13 small squares. Here, it is 15 small squares. 15 big squares. The small squares. And here there is a missed beat. So what we can conclude is that the PR interval prolonged progressively. And there is a skipping of a beat, which means that it is type 2 AV block. Mobitz type 1 is called Wenke-Back phenomena. Progressively increasing the PR interval, then skipping a beat. Here also progressively increasing the QR interval, then skipping a beat. Like that. It is irregular rhythm. Next comes the QRS complex. In QRS complex, you could see here, in QRS complex, in lead 2, you check that how much QRS complex is there, how many small squares. It is 1, 2, 3 small squares. This QRS complex is 3 small squares. QRS. Okay, so it is 3 into 0.04, it is 120 milliseconds. So there is no much problem. The QRS complex is normal. Next, the ST segment. You check the ST segment clearly. Any problem in that? You check every lead ST segment. The lead 1 you check, the lead you check, 3. So no lead has shown any ST segment elevation or depression. So ST segment is flat. No ST elevation, no ST depression. That's a ST segment. What about T wave? T wave. You see T wave, it seems normal everywhere, but there are T wave inversion in V1, V2, V3. V3 is biphasic T wave. So it's T wave inversion in these leads. So you finally give it as T inversion in V1 to V3 leads. Just check any other lead has a T wave inversion. You see here also it is AVL. So AVL has also T inversion. Then we check for any blocks. In V1 to V6, you check, you find any blocks are there, any RSR dash pattern or M pattern you can observe. In V1, there is a notch in the QRS complex here, and there is RSR dash pattern. Here is also RSR dash pattern, and in lateral leads, there is slurring of S wave. That is slurred S, and here R is R dash pattern. So it comes to diagnosis of right bundle branch block. Right bundle branch block. Finally, you see in this ECG that this ECG is a case of right bundle branch block, Mobitz type 1, that is type 2 heart block with left axis deviation. So we here write the final diagnosis. This ECG is of Mobitz type 1 heart block, or it is called Wenke-Back phenomenon with a left axis deviation with right bundle branch block. Probably in due course of time, the patient may require pacemaker. So the collapse of this patient is most probably due to the bundle branch block as well as the type 2 Mobitz type 1 AV block. The T-wave inversion that we have observed here in anterior leads is probably because of the right bundle branch block. You see, in Caucasians, V1, V2, V3 T inversion is normal. But here it cannot be normal, it should be taken into consideration. So this is the final diagnosis of this case.